Move on to arterial blood gases. There's lots of reasons to arterial blood gas. It's a commonly performed investigation in A&E and in hospital, but really they're not always needed. Sometimes I see arterial blood gases done when they're not necessarily needed. And the question to ask before you do an arterial blood gas is why? Why do I need this arterial blood gas? And the reasons why you'd want one is to assess oxygenation, look at the PO2, and to also assess ventilation. Will a venous gas suffice? Venous gases are not bad for looking at the metabolic state of the patient, but if there's a profound tissue acidosis, the pH may, I've said rise there, but that should be lower, so you get a lower pH. They may be more acidotic on the venous side than they are the arterial side. But venous gases, obviously you can't use them for respiratory assessment, which is what we're talking about here. So the PCO2 will obviously be higher on a venous gas, as will the PO2 will be lower. So decide whether you need an arterial blood gas or whether a venous will suffice. Where do you take the gas? The most common site is the radial artery, and the radial artery can be found lateral to the tendon of flexor carpi radialis, and in between that and the styloid process of the wrist. Okay. Allen's test. Who's heard of an Allen's test? Yeah, you've all heard of it. Not done very much, actually. I see people taking blood gases all the time without doing it. You probably should do it. And in an emergency situation, it's probably fine to miss it, but you probably should do it. It's to check that there's a good collateral circulation of the superficial palmar arch, and you hold both the radial and the ulnar side together, clench fist, they open it up and it looks white, and you release the ulnar artery to see whether that perfuses the hand, because one of the complications of doing a blood gas is a hematoma, and it's an end artery, and if you don't have a collateral circulation, then you could have an ischemic hand. So it's always important to do that. And when you do a blood gas, you're going to take a small amount of blood, not very much. You only need probably about 1 or 2 mils, and you want to avoid clotting. So you take it with a heparinized syringe. And the most important time to stop clotting is within the first 30 seconds to a minute. If the clotting process starts before the blood's become in contact with the heparin, there's no way to stop it. So it's really important to make sure that once you get the blood in the syringe, you give it a quick twist. There's no point doing it 2 or 3 minutes later, waving it around like people do on their way to the blood gas machine. Do it early, because if it clots, you're going to clog the blood gas machine and people will be very angry with you. So avoid clotting. And avoid further gas exchange whilst it's in the machine. Try and get rid of any bubbles. Don't leave the cap off, that kind of thing. But again, just a top tip, when you've got a bubble there, be patient with it. You can put the plunger down and up to try and get rid of it, but don't shake it, because it will go all over your shirt and you'll look like a complete muppet. So don't do that. Where else can you take arterial blood gases? What other arteries can we use? Femoral, yeah. So femoral first. So arterial in the radial artery, go for that one first. Easily accessible. Groins are dirty places, even in the cleanest of people. So try and avoid that. There's also more complications associated with it. So then go for the femoral. And you can also do the brachial, but there's a high complication rate with brachial, so try and avoid it. Especially be aware of when you're putting a venous cannula in, not to cannulate the brachial artery, which I've seen done a couple of times. Okay, when you do a blood gas, make sure you write them in the notes, because they usually come out on a thermally printed paper, which will perish with time, and you go back through notes, that are several years old, and you find the blood gas has completely disappeared. So make sure you write them in the notes. It also shows that someone has looked at it as well. Note the time that you do it. If someone comes in very sick, often they'll not just get one blood gas, they'll get a series of blood gases. And if you're just trying to decide what's going on with that patient, whether they're getting better, whether they're getting worse, you need to know what time the blood gases were done. So note the time. Always note on how much oxygen they're on, or FiO2, the fraction of inspired oxygen, and we'll go through that a bit later. And how you're giving the oxygen. Are you giving it via nasal cannulae? Are you giving it via a non-rebreathing mask, controlled oxygen? Sometimes you see people with the oxygen mask up around on their eye, you're giving intraorbital oxygen. And always note the peripheral oxygen saturation. And make sure you look at all the numbers. One of the biggest reasons for doctors getting sued is that they order tests and then don't look at them. You'll get all sorts of information on a blood gas. You get the sodium, the potassium concentration, the glucose. Make sure you don't miss hypoglycemia or high potassium. You need to confirm high potassiums with the blood. You confirm any abnormal results such as glucose or hyperkalemia with a venous lab done sample, so beware of that as well, but make sure you look at all the numbers. This is acid-base balance that you probably remember from your preclinical years, and it basically says that CO2 plus water are in a dynamic equilibrium between bicarbonate ions and H plus protons, and H plus is acid. The more H plus you have, the more acidic you'll be, and because pH is the minus log of the hydrogen ion concentration, then the more protons you have, the higher that H plus, the lower the pH. Okay, so more acid, low pH, less acid, or if they're alkalotic, you'll see a high pH. And what information do you get on the blood gas? You're going to get the pH, and the normal 7.35 to 7.45. You're going to get the PCO2. This is the partial pressure of carbon dioxide dissolved in the plasma. That's how we carry carbon dioxide, it's dissolved. Oxygen we carry bound to hemoglobin. So that's why we look at the oxygen saturation. Okay? What we get here is the PO2, which is the partial pressure of oxygen, and that's dissolved in the serum plasma, okay? So it's not the oxygen saturation. We don't carry or give up oxygen like that. We carry it bound to hemoglobin, and hemoglobin gives it to the tissues. So if you like, it's almost a surrogate marker of tissue oxygenation. Of course, delivery of oxygen is reliant upon your cardiac output as well. So it is rather limited, but you can say if there's a low PO2, then they may or may not be in respiratory failure. We'll go through that later. You also get the bicarbonate ion concentration, and that's important. The usual for that is 20 to 24. And we also get the base excess, and the base excess ranges from -2 to +2, and it just says how much acid do we need to add to make it back to normal. I don't really like it. I don't use it very much. I just look at the bicarbonate ions and try and make my own mind up. So two types of respiratory failure, type 1, type 2. In type 1 respiratory failure, because it's respiratory failure, we're going to get a low PO2. Okay? pH will be normal, and the partial pressure of carbon dioxide will be normal or possibly low if they're breathing lots. Carbon dioxide is around 20 times more soluble than oxygen. So if you've got a defect in the lung that doesn't allow you to exchange gases, the carbon dioxide will usually be normal or low if they're panting, because we can get rid of carbon dioxide much easier than we can take on oxygen. And you'll also get a normal bicarbonate. Causes of type 1 respiratory failure can be anything that stops gas exchange. So it could be pulmonary embolism, so blood's not going into that lung. It could be pulmonary edema, where gas exchange isn't happening because of that. Or it may be that some part of the lung's missing. So there might be lung collapse, or a variety of different things may cause it. On the other hand, type 2 respiratory failure is caused where you've got hypoventilation, where there's not much gas exchange going in and out of the lung. And in this, because carbon dioxide is more soluble, and in type 1 respiratory failure we don't see a high PCO2, if we're not exchanging any gases, that PCO2 is going to build up, and we end up getting a high PCO2. And as you remember from our equation, when we go back, if there's lots of CO2 on one side of the equation and it's in dynamic equilibrium, it's going to go to the other side, and we're going to get lots of protons produced. So we're going to get an acidic environment. So PCO2 is an acidic gas. Respiratory failure, we're going to get a low PO2, and that's below 10 kilopascals or 80 millimeters of mercury, whichever one you work in. And the bicarbonate may be normal or high, depending on how long they've been like that before, depending on whether the kidneys are compensating. We'll go through that a bit later. There are only really like 6 blood gases that you really need to know, different patterns, and obviously it's a spectrum, so there are variations of it. But I want to show you each one in turn. Respiratory acidosis. So because it's an acidosis, you've got a low pH. Because it's respiratory, the PCO2 is going to be high. And I use the method of blood gases, and I've written it in this way because that's the method I use, the famed handbook method, where you look at the pH and then you look at the CO2 first. So look at the pH, decide whether it's an acidosis or an alkalosis. This is an acidosis. And then look at the PCO2 and decide whether that's responsible, whether the primary problem is respiratory or not. So could that PCO2 of 12 account for that acidosis? It's high, so yes, it could. So this is primarily respiratory problem. PO2 is low, that's 9 kilopascals, and the usual is 10. And the bicarbonate is sort of the lower side of normal. So this is all acute. The kidneys haven't started compensating for it yet, and I'll show you chronic in a minute. This is acute type 2 respiratory failure, or respiratory acidosis. there is an equation for the alveolar to arterial oxygen gradient, and that just basically says what kind of oxygen concentration have you got in the alveoli, and is that being transferred to the blood? There is an equation for it, and intensivists will be working it out non-stop on their ward rounds. But for sort of clinical practice, the most useful thing is to think logically, and is the fraction of inspired oxygen, the FiO2, how much oxygen they're breathing in, commensurate with their PO2? Let's go back to this previous slide and look at this respiratory acidosis here. PO2 is 9, okay, which is obviously low, so they are in respiratory failure. If I told you they were on air, that might not seem too bad. If I told you they were on 15 litres of oxygen via a non-breathing mask, you might think that's probably slightly worse than we thought before. So that's why it's really important to note down what kind of oxygen and how you're giving it to them. Let's move on to a chronic respiratory acidosis. So we get the same features as we did before. We've got a low pH, we get some acidosis. Then look at the CO2. Is that responsible for that degree of acidosis? 14. Yes, it could be. Then look at the PO2. That's obviously very low. But with the difference between acute and chronic, here we've got the bicarb. The bicarb is up. The kidneys are compensating, and this usually takes a couple of days to kick in. This person's been in respiratory failure for a long time. The kidneys are constantly producing bicarbonate ions to try and compensate for their acidosis and return it back to normal. So this is an acute on chronic respiratory acidosis. You may see some people with, they're not acidotic and their PO2 is fine, but they have a high bicarb and a slightly high CO2, and that may just be chronic. But this is an acute on chronic respiratory acidosis. Respiratory alkalosis, the most common cause for this probably anxiety. Because it's an alkalosis, pH is up, PCO2 is down, they're breathing it all off, and the PCO2, remember, is an acidic gas. So first thing to decide is, could that low CO2 account for that degree of alkalosis? And yes, it could. PO2 is high because they're breathing in lots and lots of air. The tidal volume or millet volume is very, very large, and their bicarb is sort of normal. We'll go to the metabolic side. Metabolic acidosis. This is profound metabolic acidosis, again associated with a low CO2. They're breathing. They're probably, say this was a DKA patient, they might have Kussmaul respiration, which is very deep tidal volume, and their PO2 again is 14, so they're breathing lots. But their bicarbonate is low, and that's the hallmark really of a metabolic acidosis. For some reading later, when you go home, if you're not going to have a drink after this, then you want to check the anion gap. And the anion gap, I won't go through it very much here, but it's the cations, the positive ions, minus the anions, the negative ions, and the normal is 8 to 12. And the idea of this is for you to be able to distinguish between a high and a not high anion gap. So whether in a high anion gap acidosis, you've got something contributing to the acidosis, like lactic acid or ketones or ethylene glycol or something like that. There are mnemonics around for you to help distinguish it. Have a look at that when you're at home. Metabolic alkalosis. Vomiting is a common cause. High pH, low CO2. Again, the oxygen's high, but the bicarbonate is high in this case because we've lost lots of acid. And this is a mixed acidosis. Again, a profound acidosis. You might see this kind of picture post-cardiac arrest when people are hypoventilated, so they've got high CO2, and they may have arrested for another reason. You've got tissue hypoxia, and then you get lots of lactic acidosis produced. You may see this after cardiac arrest. So you've got low bicarb and a really high CO2, and that's a mixed picture. They're obviously probably intubated, giving lots of oxygen because the PO2 is 43, something like that, very, very big. Okay, that's blood gases done. It confused a lot of people, and everyone's got their own method. I hope I didn't confuse anyone that uses a different method, but that's just the way I do it.